Okay, today's lecture is on coronary artery disease. So when we look at problems associated with the heart, what we're concerned about is scenarios primarily where the blood delivery to the heart is being impaired. We've already talked about the most likely reason for that would be atherosclerosis, specifically to the coronary arteries, and the most common coronary artery to be affected is the anterior interventricular descending branch of the left coronary artery, the one that we can see in this picture here. Now, a couple of things to review. We spent time after test 2 talking about the normal cardiac function, and the equation that we use that is, generally speaking, a really good one to remember, because one, it explains normal heart function, and two, we can help explain pathology when we know the variables associated with normal. Now, with the cardiovascular system, it's particularly important to realize that it's a very overbuilt system. It has a great capacity to adapt. So, for example, we say a resting heart rate is somewhere between 60 and 90 beats per minute, when the heart rate can actually go up close to 200 beats per minute when the demand calls for it. Cardiac output is the value that represents the ability of the heart to meet demand for oxygen and nutrient delivery throughout the body. And it's a function of these two other factors, heart rate and stroke volume. So if we exercise, by definition, demand goes up, we expect cardiac output to go up. We can certainly relate to this. We know that when we exercise, our heart rate goes up. And looking at this equation, if heart rate goes up, by definition, the cardiac output is going to go up. And that's important. That's a good thing. That's a direct relationship that fits the increased demand that exercise represents. We can also use this equation when we look at pathologies, because we can predict what the compensations are going to be. So, for example, when we talk about stroke volume, remember stroke volume was the volume of blood ejected from the ventricle each beat. And in a typical average sort of sized heart, it's somewhere in the vicinity of 70 milliliters or so of blood with each beat will be ejected from the ventricle. So when we're looking at systemic blood delivery, it's the left ventricle that we're talking about. But the concept applies to the right side of the heart, just that the stroke volume is being delivered to the lungs. The right pump delivers to the lungs, the left pump delivers systemically to the rest of the body. So we know this stroke volume is dependent on a number of factors that we talked about after test 2. Factors that affect stroke volume included preload and venous return and contractility properties of the cardiac muscle cells, as well as afterload. So the end result of all of those factors is going to be a volume of blood that's ejected with each beat. And when we add the heart rate into the equation, that's going to give us number of beats in a minute. So cardiac output is the volume of blood delivered to the body each minute. Now, if we have a problem with stroke volume, a pathology where stroke volume can't keep up with demand, we can use this equation and predict a compensation. And that would be an increase in heart rate. If our stroke volume dropped, then by definition, heart rate has to increase in order to maintain cardiac output. So your patient with a low stroke volume will have a rapid heart rate. Okay. By definition, if cardiac output cannot meet demand, then we have heart failure. And by the end of today, we'll be talking about what that means, about heart failure. So what we want to start off with are sort of the progression of conditions that might lead us to heart failure. So we look at scenarios where there's a decrease in oxygen delivery to the cardiac muscle wall, the myocardium. And we know that the primary reason for that is likely atherosclerosis to the coronary arteries. And that's what this picture was showing us. We can see in this blackened area here that there's been some necrosis and apoptosis of the cardiac muscle wall. That area will no longer be functional. We have a blood vessel that's showing up here as white, meaning it's ischemic. There's been a block. And as a result of that block, we've lost a number of muscle cells, and that part of the heart wall will no longer be beating efficiently. That's contractility being impaired, which means stroke volume is being impaired. We'd have to have some compensation if we're going to survive. And that's what's going to happen unless the area of necrosis is so severe that there's no cardiac output or dangerously low levels of cardiac output that can't be fixed. So in our progression that results first with some blockages but not complete ischemic thromboses, so some reduced lumen spaces, we're going to see some symptoms that indicate reduced blood flow to the cardiac muscle wall. And that's officially called angina pectoris, and that literally means chest pain. So it's not very specific. And if that's allowed to progress, we may see myocardial infarction. And that's what that picture on the previous slide showed us, an area of dead cells. Typically both apoptosis and necrosis occurs during a heart attack. This is otherwise known as a heart attack. And we're going to progress to heart failure. And possibly anywhere along the line, sudden cardiac death. And particularly in these last three scenarios, we would see some ECG, electrocardiogram changes. And those would be described as dysrhythmias. So what are we talking about here? What's our etiology? We talked a lot already about atherosclerosis. So in these scenarios, we're talking about coronary artery disease. Coronary artery disease. You sometimes see it as coronary heart disease, CHD. The problem with that is it looks a lot like congestive heart failure, with the heart word. So it's probably simpler if we refer to this as coronary artery disease and not get ourselves quite so mixed up. So the whole idea here is that in our progression from angina to the possibility of death, we have a decreased space for blood delivery. So in other words, the lumen of the coronary arteries is being reduced. Probably due to the formation of a thrombus and the plaques that grow, but possibly also from vasospasm, as we talked a little bit about. We know that there's at least one form of angina that's caused by vasospasm, but those are the sort of most common areas. So what we're concerned about when we look at these plaques is there's some plaques are described as being stable and other plaques are described as being unstable. If it's a stable plaque, it's got a very very defined and typically, relatively speaking, a thick fibrous cap on it. So if we were looking at the lumen of this blood vessel and we were looking at the atheroma that's growing on the inside of the wall, a nice stable plaque would have a nice thick fibrous capsule. The fibrocytes have enclosed it in a nice thick stable atheroma. This is not likely to break off and form an embolism. However, in an unstable plaque, what we see in an unstable plaque is we see a very large lipid core. So we had our lipid core, but in this case it's a larger lipid core. And we would probably see either a very thin or possibly even an incomplete fibrous cap. And it tends to be a larger plaque, so it's taking over a little more of the lumen. So we've got more what's referred to as stenosis, narrowing of that lumen space, and probably a little bit of erosion into the endothelium as well, a little bit of encroachment into the underlying smooth muscle layer of that blood vessel. So it's a little more aggressive overall in appearance. It's unstable, so it's more likely to be able to break off and form an embolism that's going to lodge in a smaller vessel distal to the site of this atheroma. And if it does, it's going to cause coronary ischemia. So our concern with all of this is that we get coronary artery disease that causes ischemia. And we know that in an artery, when we talk about a blockage in an artery, that's what we're concerned about, is ischemia. And there's a couple of things that are going to influence the problem with ischemia. So if we're dealing with ischemia due to coronary the two things that we're most concerned about in order to determine how severe this could be is the rate or amount of coronary perfusion. I'll explain that in a minute. And the other thing that we want to be aware of is the workload on the heart itself. So what we call myocardial workload, because we have some control over that. So if we suspect or if we know, based on a history and a preliminary examination, that we're concerned about a coronary ischemic episode, then one thing we're concerned about is the age of the heart. One thing that we know with an older heart is that it develops a corollary circulation. In other words, these blood vessels that we see here, that we can see in our picture, so this one represents our anterior descending branch of our left coronary artery, and this one that's wrapping around the other side is circumflex. We see part of the marginal artery from the right coronary artery, and this other vessel that we see in this picture is a vein. So when we see an older heart, what we will notice, I'm going to try and I'll show it up in purple, is these blood vessels, they branch. The older the blood vessels are, the more branching has occurred. And the more branching that has occurred means that a blockage in any one of those blood vessels will have less of an impact than it would if it was just the four branches supplying the entire heart. So we get a sharing and a better distribution of blood in an older heart. We talked a little bit about this after test 2, and hopefully you talked a little bit about it when you took the cardiovascular system in HAP 201. So that's one thing when we talk about rates or amounts of coronary perfusion. The more distribution of blood vessels, the less impact one of these blockages is going to have. The second thing that we got to be aware of is the myocardial workload. If we are dealing with a very fit, athletically active person who's trained their heart, at least while they're at rest, the workload will be considered light. If someone is at rest but has a poor lipid profile, the profile that we talked about with atherosclerosis, and is sedentary and overweight, then the load on the heart is much more at rest than it would be if they didn't have those lifestyle risk factors contributing to the workload on the heart. If afterload was very high, in other words, high blood pressure, then that represents a bigger workload on the heart. The longer, the more length of blood vessels, like we would see in someone who's overweight, the more the load is on the heart. So one of the sort of core treatment plans will be to address the myocardial workload. When we look at any of these conditions, one of the first approaches we're going to take is to try to address the workload, reduce the workload to the heart until we can get a proper diagnosis and treatment plan in place to ensure a better outcome. Okay, so let's take a look at some conditions here. When we look at a chronic gradual occlusion of a coronary artery, we can describe stable angina. If it's an acute occlusion, then it's probably going to be described as either an unstable angina or a myocardial infarction. So if we have a slow-growing, gradual occlusion of a coronary artery, it's described as stable angina. So our topic right here is angina. Stable when occlusion is gradual. So in a stable angina, our patient is going to have a predictable clinical presentation. Their blood vessels are narrowed, so typically at rest they can manage with a bit of a raised heart rate and so on, but their signs and symptoms are predictable. So typically they're going to complain of chest pain on exertion, maybe going up a set of stairs, maybe being stressed by some scenario in their life, that sort of thing. But the onset is predictable, and with rest, the symptoms go away. So our signs and symptoms are predictable. And primarily, because we're talking about angina, it's chest pain. And it may radiate in the classic sort of presentation that we see with a heart attack, but it goes away at rest. So our signs and symptoms are predictable on exertion and goes away at rest. So that's our stable angina. You'll see stable angina is also sometimes called typical or classic or effort angina. So you might see terms like typical, effort angina, which refers to the fact that the symptoms are present on challenge but go away on rest, and classic. Now, when we look at unstable angina, with unstable angina, it's sometimes got the word crescendo associated with it because sometimes what we see is sort of an acceleration of the symptoms, and that's kind of a classic presentation for unstable. It's a sudden onset that often progresses, and it may be an indication for an impending heart attack, an impending myocardial infarction. So in this case, there's a progression of an acute onset from a block. So this is the scenario where there's an embolism, probably at least for unstable angina, in a small enough vessel that it isn't causing a large amount of damage, but it may be an early indicator that this is going to progress. So these patients in stable, I should just mention, nitroglycerin, which vasodilates the coronary blood vessels and so opens up the lumen, will get rid of the symptomatology. In unstable, it's not going to be responsive to nitroglycerin. So the other thing about the symptoms here, sudden onset, we mentioned, may be progressive and continue even at rest. And typically, if it is ultimately identified as an unstable type of angina, it basically is likely to get worse with subsequent events. In other words, it's an indicator that the blood vessels are badly damaged and there's going to be some subsequent events later on. And if there are, they're going to be worse and maybe increase in frequency. And that's the scenario that results from a plaque that was unstable or fragile and broke and caused an embolism in a small blood vessel. The third type of angina we talked a little bit about when we talked about vasospasm in blood vessels. So this one is called a variant. It's not stable, it's not unstable, so it's a variant. The guy that put his name on it was a guy named Prinz Metal. Angina, and this one is simply unpredictable. Like some of our vasospasm scenarios that we talked about when we talked about blood vessels, there may be an autoimmune factor associated with it, but onset is not related to exercise. So signs and symptoms are not related to exercise or stress. Not, well, we got that already. I don't need to repeat that. So other scenario, any scenario where there's going to be an increase in oxygen demand probably will create symptomatology in our stable and our unstable variants, but in this one, it's not related to those types of challenges. The vasospasms or the hypercontractility may be related to abnormal environmental factors, abnormal electrolyte factors like abnormal calciums or potassium levels. You reviewed a little bit of that when you did some electrolyte imbalances. And one of the things that's a little bit unusual or somewhat diagnostic when we look at variant types of angina is that sometimes we're going to see an elevated ST wave in the ECG. Now that's classically contributes to our diagnosis for a myocardial infarction. So occasionally in a variant Prinz Metal, when they're set up on an ECG, while they're having some symptoms, they can have an elevated ST wave. So what that, just so that you get a little review on that, we'll be talking about ECG a little later today, but our ECG is a P wave and a QRS complex followed by a T wave. So this is P, Q, R, S, and T. So if we're talking about an elevated ST, then what happens in the ECG is we see this sort of thing. So rather than all this white under here, we would have an elevated ST segment. So the segment S now leaves the R and travels and sort of joins up with the T. So that's elevated ST. So again, if it's transient and an elevated ST, then we're thinking more about angina. If the symptoms are more consistent and somewhat progressive with an elevated ST, we've got to rule out a myocardial infarction, which we'll be talking about next. Okay, so acute coronary syndrome, signs and symptoms are due to a decrease in blood flow in the coronary arteries. And what we're concerned, how that's going to present is with severe chest pain, lasts longer than a typical angina does. Plaque has probably ruptured, caused a thrombus that has created an extensive blockage. And what we're going to see in these acute coronary situations are some definite ECG changes and some blood biomarkers. Those are going to be diagnostic factors for our acute coronary syndrome. So the acute coronary syndrome So all of our signs and symptoms are due to a decrease in blood flow in those coronary arteries. And these examples of these types of conditions that would fall under acute coronary are the ST or the non-ST. I'll explain this abbreviation in a minute. And unstable angina. So these all fall under acute. So what we're talking about here is ST, that ST wave I talked about, elevated myocardial infarction. Non-ST, elevated myocardial infarction, and unstable angina. So those are the conditions that we're talking about when we talk about acute coronary syndromes. And typically in all of these, what makes them similar is there's severe chest pain that lasts longer than a typical angina. In other words, even if the activity level is reduced, the pains remain. So our diagnosis depends on our history, physical, but those are going to come across as very similar for all three of these possibilities. So then what we're going to depend on is our ECG and our biomarkers. So biomarkers is a general term for factors that will be elevated, in this case, in the blood that we wouldn't normally expect to be in the blood, but are indicators of cell damage. And we have some specific ones for cardiac muscle cells, so we can be much more specific if certain biomarkers are elevated to be more sure that we're dealing with a myocardial infarction. Okay, so the classic ECG change is that elevated ST segment of the standard ECG that I showed you on that previous slide. So that's the one thing that we're looking for in that respect. Now, when we look at biomarkers, biomarkers are either enzymes that have been elevated or components that would normally be inside the cell membranes of those cardiac muscle cells that because of apoptosis and necrosis, the cell membrane has been interrupted, and some of those factors have been able to escape into the circulatory system and are measurable. So we'll talk about those in just a couple of minutes. So who's at risk for this? Who's at risk for this? The same profile that we talked about for atherosclerosis. So we know there's lifestyle factors: smoking, obesity, sedentary, stress. Those are all factors that play a role in the development of these acute coronary syndromes. There is some non-modifiable risk factors up to about the age of 50, maybe mid-50s. Males have a higher risk for this sort of thing, and after the age of, say, 55, the risks start to even out. And in the interest of female equality, historically, females smoked less than males. Nowadays, females smoke a bit more than males. In most studies indicate that the female group has actually, while a lot of male age groups have reduced their smoking habits, females haven't reduced it to the same degree. So there's a catch-up there. And we think that estrogen in the premenopausal women has a little bit of a protective factor on the heart, and women, once they get into their mid-50s, lose that protective edge to some degree. There's no real strong evidence that suggests there's anything dietary that is going to play a factor. The reality is that if you eat foods that are high in saturated fats or high in cholesterol, that we have a liver and we have enzymes within our body to deal with those sorts of things. Dietary cholesterol is a very, very small percentage of the total cholesterol that we measure in the circulatory system of humans. So that's not such an issue. Trans fats, another story. Trans fats, synthetic fats, if you like, they do have a measurable risk associated to the cardiovascular system. So other factors that will increase the risk for cardiovascular issues are diabetes mellitus, high blood pressure, our poor lipid profile. As we get older, there's a few genetic variants that show an increase in risk, those sorts of factors. That pretty much the same thing we've already spoken about with respect to atherosclerosis. So what's going to happen in the scenario? Let's see here. What do we got? Here's our picture. So here we see in this diagram, what we're seeing is the development of atherosclerosis. We could argue that that's our yellow streak or our fatty streak that shows up, but we can see that in the center of this lumen it's being blocked. And as a result of it being blocked, we're going to have ischemia distal to that site of blockage. And when we have ischemia distal to the site of blockage, the cardiac muscle cells are no longer receiving oxygen or other nutrients, especially glucose, and as a result, they can't make ATP, and so we're going to get our progression of damage as a result of all of that. So what we see in our progression is we have our blockage, and that blockage is going to create what's called an ischemic cascade. So in other words, the ischemia is going to ultimately result in apoptosis and necrosis. So this is an example where we get a combination of cell death, apoptosis and necrosis of cardiac muscle cells. So basically, what we're going to see, of course, is that same cascade that we talked about when we looked at ischemia a couple of weeks back, where that's a decrease in oxygen and glucose, decrease in ATP, failure of the sodium-potassium pump, And that's what's ultimately going to give us our cell death. And again, like I mentioned, some of this can be altered slightly depending on collateral blood supply, the relative oxygen demand. So if this patient can be resting, they have a better chance of minimizing the damaged tissues. But if those two factors aren't present, in other words, it's a younger heart that's active under exertion at the time of the event, then the size of the infarct, the size of the damaged area, so this area where there's been cell death, is what's called the infarct. Okay, so we consider collateral blood supply, we consider the relative oxygen demand, and then lastly we consider the size of the infarcted area. So all of these will determine the prognosis, determine the outcome. If we have a lot of collateral blood flow, then we're in better shape. If we can keep the heart kind of quiet, reduce the relative oxygen demand, we have better recovery ability. If the size of the infarcted area, in other words, if the other first two things don't match up favorably for us, then we're going to have an increased size of damage, and that's going to reduce our outcome. The larger the area that's been damaged, the more likely the recovery is going to be limited. So typically, the visual changes to the heart wall will occur very quickly. First of all, we have ischemia, so the area will become pale initially, and then it gets, during the remodeling and recovery or repair phase, it gets a little bit yellow and soft. The necrotic tissue is cleared after a couple of weeks, and we're going to be left with some scar tissue. And if we have scar tissue after 4 to 6 weeks or so, we've got loss of function by definition. Those cardiac muscle cells cannot repair by regeneration. They have to repair by replacement. Scar tissue, by definition, loss of function. We should remember that from when we talked about tissue repair. So because of the scar tissue, we can expect an increased chance for dysrhythmias. Remember, after test 2, we talked about the conduction system of the heart. So here's our 4 chambers, and we had our pacemaker, the SA node, and we had the AV node. And when we signaled the pacemaker, we sent waves of stimulation through the atrial walls and to the AV node. But at the AV node, we have some resistance. And that resistance slows down the electrical signals to the muscle cells in the ventricle. And we pass through bundle branches, down the interventricular septum that separates the two ventricles, to bundle branches, right and left, bundle branches, to finish on Purkinje fibers that then began the electrical syncytium from the apex of the heart back towards the respective valves in the ventricle. So we had the AV valves like that. And we had our semilunar valves, the pulmonary valve and the aortic valve. that allow the blood to leave the respective ventricles. Okay, so we want to be very aware of this conduction system. So now this conduction system works fantastic. The atria contract from the top down towards the AV valves, and the ventricles from down up towards the semilunar valves, so that we have nice, consistent, coordinated contractions. The analogy that I used was like squeezing the tube of toothpaste from the bottom in each case, so that we're not squeezing from the middle and having things go in other directions. That's really the role of this conduction system. This passageway, this delay between atrial contraction and ventricle contraction, and the waves of contraction through the myocytes acting as a syncytium, a functional syncytium, so that we get one-way flow through the valves in a timely fashion. Atria contract before the ventricles, so the ventricles are given a final spurt of blood and are filled, preloaded, to a final stretch before they contract. Right? That's all the stuff we were talking about last week, 2 weeks ago, maybe now, depending on when you're listening to this recording. So if we end up with scar tissue, for example, if we have scar tissue, why is that going that color? Oh, because, here we go. If we had scar tissue, for example, on the anterior surface, then what that's going to do is force the electrical wave to skip past that area. So that's why we might end up with an ECG abnormality, some sort of abnormal wave in the pattern. So we expect our ECG to be pretty consistent with our P, Q, R, S, and T wave repeatedly, 60 times a minute, 90 times a minute, shows that pattern. But if we see any interruptions in those patterns, either some skipping or some extended lines between the QRS complex and the P or the T, then this can be attributed to scar tissue on the muscle wall after the remodeling phase of the repair has occurred. Okay, let's put in a new layer here. Okay, now, when we look at this individual that has gone through or is going through the symptoms of a heart attack, our diagnosis, we've mentioned this already, is based on physical and historical examination. Then we look at the ECG, and then we look at the biomarkers. So our physical and our history, this patient may give you a lot of the presentation of modifiable factors. They're overweight, they're a smoker, they have a poor lipid profile. All those things would fall under the physical category. The history might include, whether there's a family history of cardiac issues, whether there is previous history in the individual of cardiac issues. Those sorts of factors come into play. So the ECG might show that elevated ST that we've been talking about, but the biomarkers are what we really want to look at and be aware of. So the pain that someone would go through is often described as a crushing pain. It's in the chest. It might radiate to the jaw or the shoulder, more often to the left, but not necessarily to the left. Not going to be relieved by that nitroglycerin, so we rule out stable angina but based on that. The pain may be severe enough they feel like they want to throw up, or they do throw up. They'll be sweating, they'll have difficulty breathing. And occasionally there's something that's called a silent myocardial infarction, where we don't see the chest pain. We don't see an individual that's in stress until very late in the presentation. And that's a little more common in females and in the very old, elderly. So we mentioned the ECG would have an elevated ST segment, And we might also see increased Q waves. So the Q wave was the first part of our QRS complex. So we see a deeper, larger Q wave. So if we wanted to draw in both, so let's here's our P, Q, R, S, T. Okay, so if we go in yellow, when we talk about a larger Q wave, we may see a dip down like that, and the elevated T wave joins up so that the T, I'll put these, so this is P, this was Q, R, S, and T. Okay, so a larger Q wave means we're going to see a larger dip in the QRS complex, and the elevated ST means we sort of skip going back down to the flat line for electrical activity and instead see the elevated ST segment there. Now, with the markers, they're also sometimes called serum markers because they're going to be found in the blood. Some are better than others. So these are released from the damaged muscle cells and include myoglobin. Remember, myoglobin was a lot like hemoglobin, except that it's unique to muscle cells. They have their own ability to store oxygen, but unlike hemoglobin, which unloads oxygen for all the cells in the body, the myoglobin unloads oxygen only for the muscle cell. So it's a completely internal delivery system, not an external one. So myoglobin and troponin. Troponin is the regulatory protein that binds with calcium to change shape to allow myosin and actin to be able to form cross bridges and then power strokes to create contraction. So this troponin gets released into the circulatory system as well. And another biomarker is called creatine kinase. So it's an enzyme. It's abbreviated as CK. And it's an enzyme. Obviously, it ends in ASE. It's an enzyme, but it'll be elevated in damaged cardiac muscle cells. So the one that we like the best is troponin. Troponin is our most diagnostic biomarker for a heart attack because it's most sensitive for identifying myocardial damage. So we describe it as being very, very specific. Particularly, there's subtypes of troponin. Some people might remember that troponin was kind of a three-globular molecule, and one was called troponin C, because it's the one that has a binding site for calcium. There's a troponin I, which is attached to tropomyosin and inhibits contraction. So there's an I. And then we have our troponin T. That's the part that actually binds to troponin and causes inhibition, tropomyosin, I should say, to block the binding sites for myosin and actin so that we get resting in the absence of calcium. So when we look at the subtypes of troponin, it's troponin I and T specifically that are diagnostic for a heart attack. Diagnostic because these are the ones that are going to be known to come from cardiac muscle cells in combination with the history that we've been taking. And they're released very quickly. So they're released within 2 to 3 hours. So someone has chest pain, Maybe they fall over, they complain of this crushing type of pain in their chest. You can take blood work within a couple of hours and see elevated levels of this troponin. Now it's going to peak at about 12 hours. But it's measurable at 2 to 3 hours. That's why it's such a great classic marker for a heart attack. Now the creatine kinase, specific to the myoglobin of the cardiac muscle cells, is also a specific variant for cardiac muscles, specific to cardiac muscle cells, but it's a little bit slower to reach a peak. So it might take up to maybe 24 hours to reach a peak. So it won't be as measurable in significant amounts quite as quickly as the troponin is. And then finally, we can look at myoglobin. So myoglobin, it peaks very quickly, but is described as being non-specific. So in other words, any kind of muscle damage will show elevated levels of both of these two. So the problem with the myoglobin component, which we see in both of these, is that they're not uncommon in other muscle tissues. So let's say someone had a heart attack, or we believe somebody had a heart attack in a car accident, but they also hit their chest on the steering wheel. So there's damage to the pectoralis major muscle, for example, skeletal muscle. Myoglobin will be released from the damaged skeletal muscle, so it's not going to be diagnostic for the heart attack. We might believe the person has a heart attack, but we can't depend on those two markers because they're not as specific as the troponin marker is. Now, there's some other markers that are elevated during a heart attack, some other enzymes. There's an enzyme called lactate dehydrogenase, LDH, that peaks maybe 2 or 3 days after the heart attack has occurred. But again, not as specific and slower, so it's not going to be helpful until there's several days have gone by. So what's happening in this acute myocardial infarction? We know that the myocytes are going to die. They die through two separate pathways. They die from apoptosis and they die from necrosis. We know that the number one cause of necrosis in many cells of the body is from ischemia. So here's one of our examples. So we're going to get the problem with myocyte death. So if I use this abbreviation MI, we know we're talking about myocardial infarction. Cardiac muscle cell death. And that means that we're going to have decreased contractility of the heart wall, the myocardium. So if we have decreased contractility, we're going to have a reduced stroke volume. And that's going to require an increase in heart rate. So during a heart attack, your patient is going to have an elevated heart rate. Not only are they in a lot of pain, acute pain, we know stimulates our sympathetic nervous system, but we're also going to be trying to compensate. So these things, though, equal an increased workload on the heart. So that fight or flight response is working against us under these conditions. So we've got an increased workload because of the increased demand on other parts of the heart wall and the stress of the presentation. And that's going to potentially give us a problem, right? That's going to potentially give us a problem. But the decreased contractions, remember I use the square brackets for contractions. Does that work okay for, well, maybe I better not. Interpretation later on. So decreased cardiac muscle. Now I'll put the brackets in here so we understand that's decreased cardiac muscle contractions. By definition, means cardiac output is going to go down, but then we're going to increase our sympathetic nervous system, which means we increase our heart rate. So this represents compensation. Going back to our cardiac output is a function of heart rate times stroke volume. So this is a decrease in stroke volume. This is an increase in heart rate, trying to maintain the cardiac output. So what's our treatment plan? Number one, decrease the oxygen demand on the myocardium. So that might be simply trying to get your patient to relax as much as possible. You're in the emerge department, you're on a gurney, we're going to look after you. It's important that you try to relax. We want you to, we want to reassure you that you're in the right place, those sorts of things. We may also want to apply antagonists to the sympathetic nervous system. So things that will reverse or dampen the fight or flight response. Maybe some pain relief is helpful. And anything we can do to decrease afterload. Because if we decrease afterload, we're actually, all of these things are actually contributing to the decrease in oxygen demand. Okay, so that's the goal. We want to decrease oxygen demand. Now, the second thing we can do so in our treatment, first, decrease oxygen demand. Second, increase oxygen supply. So when we increase oxygen supply, we may have to reestablish blood flow in the coronary blood vessels. We may have to apply some medications that are designed to bust up the thrombus, thrombolytic medications. We may introduce angioplasty, the balloon or the stents, to reestablish blood flow. We may have to do a graft, a bypass surgery, in order to increase those oxygen supply scenarios. So, and then we watch for dysrhythmias and any kind of conduction disorder that might interfere with the sequences of contractions and the ability of the ventricle to eject a volume of blood that's large enough to meet demand. So during a longer term cardiac rehab, we can apply our DES principle to the treatment plan as well in the rehabilitation side of it. So we want to educate on lifestyle, a good balanced diet that's not heavy in particularly trans fats, probably heavier on green leafy vegetables and foods that have been less manufactured and more naturally produced will be helpful generally. An exercise program that may have to be begun moderately but progresses. and then also good sleep and also stress management. That's what we're talking about when we talk about those principles of death for our rehabilitation. Now, this chart, you can find this same chart in your PowerPoint. Signs and symptoms of cardiac ischemia. The presentation, the working diagnosis, the ECG, and the cardiac biomarkers. What are we looking for as we move down? And then our final diagnosis. Over here, acute coronary syndrome. If we have no changes to the ECG, then we continue on and look at biomarkers. If we have no biomarkers, then maybe what we're looking at is an unstable angina. Remember, it started with acute. Signs and symptoms of cardiac ischemia. If we have an ECG change, an ST elevation, and we're positive for biomarkers, we're talking about an ST elevated myocardial infarction. Positive for biomarkers means we have those elevated levels, particularly of troponin I and T, but also probably we would see CK, MB, and MB. And over here, with no elevated STs, we got the possibility of unstable angina or what's called non-ST elevated myocardial infarction. So the ST elevation does not guarantee that we're having a heart attack. We can have an ECG that is elevated, ST segment is elevated, or not elevated. In both cases, we could still be dealing with a myocardial infarction, and the difference maker is the biomarkers. Okay, now what happens when we perfuse the myocardium? So in other words, we reestablish blood flow to the myocardium. So, well, sorry, we won't get there just yet. What we're saying here is we have a decrease in myocardial perfusion. So this is just showing us a progression. If it's partially ischemic, we're going to switch to anaerobic metabolism. It's going to give us some ATP reduced, but also an accumulation of lactic acid. And that's going to reduce our ion pumping capabilities, our sodium-potassium pump. We're going to get leakage. We're going to get changes. As soon as we get electrolyte imbalances, we're thinking of dysrhythmias. If we totally block, no ATP, no contraction, cell death. Decreased cardiac output, sympathetic response, abnormal ECGs, abnormal biomarkers, and we're talking about a myocardial infarction on this pathway. So that's how you can look at that chart and help yourself understand the progression of injury, depending on whether it's a complete block or a partial one. Okay, so we're going to move on to heart failure. So when we look at heart failure, in heart failure, what we're talking about is literally we can go back to this equation. Cardiac output is a function of heart rate times stroke volume. We know all the factors that contribute to these things. But whenever cardiac output fails to meet demand, we have heart failure. So it may be the result of a very high afterload where the heart cannot overcome the resistance on its contractions. There could be some congestion in the lungs that interfere with exchange and proper flow to the left side of the heart from the right side. There may be compensations that are not adequate after factors like we've been talking about, a heart attack and those sorts of things. And it's a relatively common condition. Probably some of you have already been in placements in the hospital where you've seen patients that are in heart failure. It's sometimes called congestive heart failure, and we can define it based on whether it's the right side of the heart or the left side of the heart that's the cause of the problem, or sometimes it's both sides of the heart that are the source of the problem. So when we look at the etiology, for heart failure, the most common etiology is that it's a complication or a sequela to a myocardial infarction. So it is most commonly due to consequences from the myocardial infarction, and may also develop from high blood pressure. And what we're concerned about, or we could have some congenital issues with the heart wall that make it weaker to contract and so on. But the most common ones are going to be related to history of myocardial infarction or the presence of long-term hypertension. So in heart failure, the signs and the symptoms, because by definition, this is chronic. So we're not going to see the same sort of acute presentation we saw in the myocardial infarction. We see dyspnea, which is a general term for difficulty with breathing. We may hear pulmonary rales, which indicates pulmonary congestion, fluid buildup in the lungs. The heart may be enlarged. We're going to explain how all this develops. Pulmonary edema. And probably because of compensation, tachycardia. Tachycardia, fancy word for an increased heart rate. And we can describe heart failure as either a problem with systole, which was the contractile phase, or diastole. So we can have a systolic or a diastolic dysfunction. Heart failure can be due to systolic abnormality or diastolic abnormality. So if it's systolic, you're thinking about all the things that are related to contraction. So the myocardial infarction is your classic example. We've got loss of functional components of the myocardial wall, so we're going to have problems with contraction. It's going to be a weaker contraction. That's systolic. If it's a problem with blood flow return, venous return, that would be a diastolic problem. So when we're looking at, let's see here, if it's a systolic problem, then we have decreased contractility. Which means we're going to have a lower ejection fraction. Remember, the ejection fraction was created from our end systolic volume against our end diastolic volume, and that gave us an inverse fraction. So if we just kept our numbers simple, or if our end systolic volume, the amount of volume of blood in the ventricle at the end of contraction was 30, and we started with 100, the end diastolic, the end of filling, then our ejection fraction by definition would be 70. 70% was ejected. So our ejection fraction, we can determine it from the understanding the volumes of blood that are at the inside the ventricle at the end of systole and at the end of diastole. So that's going to give us our ejection fraction. We want a normal ejection fraction is somewhere between 50 and 70 milliliters. If we get much below 40, it's by definition described as being heart failure. So with a loss of muscle cells, we're going to have a lower ejection fraction. We're going to have a weaker contraction. That's sometimes also known as a decrease in inotropy, strength of contraction. If it's a diastolic problem, and this could be because of the coronary artery lumens are so small or the afterload is so large that we're going to have what's called ventricle non-compliance. It doesn't fill properly. So the ventricle so up here we said end diastolic volume was 100, so there was no problem with filling. But the problem, so this was normal. The problem with a decreased ejection fraction, when we look at a decrease in ejection fraction in a systolic problem, then that ejection fraction is dropping towards 50, then maybe 40. So that's a problem. Okay, in the diastolic abnormality, the ventricle doesn't fill properly, so we maybe don't get to 100 to begin with. Maybe we only fill to 60. So even if we had a good ejection fraction, in other words, good contractility, we don't have much volume to begin with. So even if we're 70% as an ejection fraction, 70% of 60 is about 40. We're in heart failure when we have an ejection fraction that's around 40. So that means our end diastolic volume is too low. So this was normal. Just so we're clear, these numbers represented normal. So what we're talking about is in decreased contractility, our ejection fraction is going to be less than 40. Right, and in this case, our ejection fraction down here under diastolic may be just fine, but we don't have proper filling to begin with. So that's the difference between the two. And in both cases, we have a decrease in cardiac output. And in both cases, what's going to happen is we're going to start to see some backflow. We're going to see things start to back up. And that results so it's going to start what we call a backward effect. Things are going to start to back up. So initially, we're going to try to compensate. To try to increase our cardiac output. So one of the things that we're going to try to do is we're going to increase our sympathetic nervous activity. That's the nervous system, that's going to be fast. And we're going to try to increase preload. Preload was the stretch on the cardiac muscle wall. And when we increase preload, we're probably going to see, so this one leads to the other, cardiac muscle hypertrophy. So we're going to see these kinds of changes in the heart in response to this poor cardiac output. We're attempting to improve the cardiac output, and ultimately it becomes detrimental. And our management, so all of this becomes more of a stress on the heart, and it's going to become progressive. It represents a positive feedback. It doesn't fix the problem, but our system is designed to try to continue to fix the problem even though it's not working. So it becomes a type of positive feedback. So management is going to be directed towards minimizing the detrimental factors that come from these types of compensations. So these compensations look a little bit like this. In heart failure, we're going to see some compensation. So we're going to see baroreceptors that respond to the low blood pressure, sympathetic activation, designed to increase heart rate, increase contractility. That should help correct cardiac output. At the kidneys, we're going to promote fluid retention. We're going to activate the renin-angiotensin pathway because of the low flow to the kidney and encourage the production of aldosterone and angiotensin II that promote fluid retention and will increase blood volume. By definition, we're going to increase preload. If we do increase preload, we're going to increase ventricular wall tension. That's going to promote myocyte growth. We're going to get hypertrophy. Okay, now hypertrophy becomes a problem if it's excessive. And by that, what I mean is by looking at this graph. So if we look at this little depiction here is good. We talked a little bit about this after test 2. So in this diagram here, we're looking at Z-line myosin thin and thick filament overlap. So when we have good overlap between the Z lines, we've got good contraction. Now, if we overlap too much, the muscle gets weaker because it doesn't have the distance to contract. Remember, we said that when we put a stretch on the wall of the ventricle within range, that becomes a stronger contraction. But if it gets too big, we lose the benefit. So if the integrity between actin and myosin is lost because the cardiac muscle cells grow too big, then the contraction gets weak. So that's the danger with cardiac muscle hypertrophy. If the distance between the Z lines gets too big, we lose the integrity between myosin and actin. So ultimately, we say that preload is good, but too much preload is bad. Cardiac muscle hypertrophy is good until it gets to be too much, and explained this way. Hopefully that's understandable, and if it's not, email me with questions, or we can talk about it at the beginning of our next class. Okay, so that was addressing these things right here. So basically those cells are going to try to remodel, right? There's a new stress on the heart wall, and as a result, we're going to get some adaptation. Early on, the adaptation is beneficial. If it's continuous, it becomes harmful. It's going to create a loss of integrity at the sarcomere level, and that's going to interfere with our ability to contract effectively. So when we look at heart failure and we look at what's going to happen both forward and backward, it sometimes gets a little bit confusing. So, for example, we've got a diagram right here. Okay, when we look at this diagram here, we've divided the heart in this diagram into the right pump, which is going to deliver to the pulmonary circulation, and the left pump, systemic. So these represent capillary beds systemically. So when we look at the left heart, everything going in this direction is forward. Everything going this way is backward, behind the left heart. When we go backward behind the left heart, we're going to the lungs. So if we're looking at left heart failure, the backward effects are going to have a direct effect on the lungs. The forward effects will have a direct effect on systemic circulation. If we're looking at right-sided heart failure, the forward effects will be on the lungs, and the backward effects are going to be on the venous system behind the right heart. So remember what we talked about with backward effects on the venous system was edema. Backward effects on the left heart will show edema in the lungs. Backward effects in the right heart will be systemic edema. Okay, now I show you this picture first, and then I draw it another way that may hopefully be a bit helpful for you. Because here's another way we can draw our circulation. We can divide the heart into two chambers. And that's the right side of the heart. This is the left side of the heart. So this is left. This is right. And we'll draw the systemic circulation this way. We'll draw in a capillary network that looks a little bit like this. Okay, and so what we've drawn in here is the right side of the heart. Whoops, I wanted to do this. This is our right atrium. This is our right ventricle. This is our left atrium. This is our left ventricle. So what's in between the two are the lungs. So the right pump is responsible for pumping blood to the lungs for reoxygenation. And then that blood is pumped or delivered to the left atrium so that the left ventricle can pump to the entire body. Right? So this is the heart schematically drawn to divide up the right pump and the left pump. And this way we can illustrate forward effects and backward effects a little bit easier. At least I think it's a little bit easier. So for the left heart failure, if we're talking about left heart failure, forward effects are everything going forward. Remember, blood flow is one way. So if we're talking about forward effects, we're talking about forward moving. So the blood that's leaving the heart, everything that leaves this chamber will be forward. When we leave the right chamber, forward effects are going to go towards the lungs. When we leave the left chamber, forward effects are going into the systemic circulation. If we talk about backward effects from the left side of the heart go to the lungs. Backward effects from the right side of the heart go into the systemic circulation. So in left heart failure, so this would be our right heart failure on this side. So in heart failure generally, cardiac output fails to meet demand. And it doesn't matter whether we're talking about right side or left side. In heart failure of any type, ultimately, there's a decrease in cardiac output. And if that cardiac output cannot meet demand, by definition, we have heart failure. Doesn't matter if it started here or if it started here. There's going to be a decrease in cardiac output. It's a problem defined as heart failure. So clinically, left heart failure is more common than right. But left heart failure is ultimately going to lead to right-sided heart failure. So in other words, the most common cause of right-sided heart failure is left-sided heart failure. So, and we'll explain why, because as we go backwards, we put an increased afterload on everything that's behind the new backward effect. And so, for example, if we have poor cardiac output leaving the left ventricle, that means there'll be less blood, there'll be more blood accumulating in the left ventricle after contraction, which creates a backward effect on the left atrium, which creates a backward effect on the pulmonary circulation delivering to the left atrium. So that's going to create congestion in the lungs. And if we just, because it's a closed circuit, we just continue going backwards. If we get congestion in the lungs, that represents afterload to the right ventricle. Now remember, we said the right ventricle muscle wall is smaller, is much less than the left ventricle wall, because normally the right ventricle only has to pump to the lungs. There's not a lot of distance, there's not a lot of resistance. So the afterload that the right ventricle has to overcome is very, very low. So the heart muscle wall is much thinner. But it also means that if we congest the lungs, we create a larger afterload to the right ventricle. The right ventricle is going to fail sooner than the left one. And if we keep going backwards, we end up in the systemic circulation. Increased resistance in the right side of the heart pushes a larger volume of blood back into the venous side of the systemic circulation, and we know what's going to happen with backward effects in the venous system. It's going to result in systemic edema. Backward effects on the left ventricle give us pulmonary edema. That's the noisy breathing and the fluid on the lungs. No matter the cause, right or left, the problem is the same, a decrease in cardiac output. We can appreciate, because it's a closed system, if we started the problem here, then going forward, we're going to have this problem. Poor contractility here means poor delivery to the lungs, means poor delivery to the left atrium, poor left ventricle contraction, because the venous return has been reduced because of right-sided failure. So what are we going to see in somebody with a cardiac output that does not meet demand? That is described as our forward failure. And the signs and symptoms of somebody that is in forward failure, in other words, cardiac output is failing to meet demand, heart failure, we're going to see confusion, we're going to see fatigue, we're going to see compensation, an increase in heart rate. It's probably going to be weak, depending on when. Probably a decrease in urinary output because of compensation at the kidneys, trying to reestablish a blood volume, even if it's not a blood volume problem. And we're going to redirect blood flow from the periphery centrally to try and reestablish cardiac output. Decreased peripheral circulation. So these things all represent compensation. Remember, we said the nervous system compensated, the renal system compensated, and we get cardiac hypertrophy on top of all of that, that ultimately we've seen is going to lead us to muscle weakness. Let's do this. Let's put in a layer here. So, for example, if we follow the left ventricle, if we said we had left heart failure, and we wanted to look at what's going to happen backwards and what's going to happen forwards. So we'll go forward and backward. Okay, so again, think about that drawing on the previous slide. When we look at our, if we're going to start right here. That is going to be a problem. So if we start with the left ventricle, that's what we're going to look at in this slide next. So here we are. Ready to go with forward effect. So when we look at our forward effect, we know we're going to have a decrease in cardiac output. And we know that in compensation, we're going to get an increase in our renin-angiotensin activation. And that's going to increase fluid retention. And our decreased cardiac output is going to cause a decrease in tissue perfusion, which is going to increase the sympathetic nervous system, which we know is going to happen in compensation as well. And when we do that, we increase heart rate, we increase contractility, and we get hypertrophy. So our heart is going to enlarge, and eventually that becomes a problem. With our decrease in tissue perfusion, we get decreased oxygen delivery to the tissues. That's where our fatigue and our confusion comes from. So we said hypertrophy, we said an increase in sympathetic, and our renal. Now, backwards, because we remember our problem is with the left ventricle or the left heart, and it's going to be the muscle wall of the ventricle that we're talking about. When we go backwards, we have a decreased ejection fraction, which means there's more blood in the ventricle after contraction. If there's more blood in the ventricle after contraction, what that creates is an increased ventricular preload, right? Because instead of having, say, 30 milliliters in the ventricle, now we've got 40 or 50 milliliters in the ventricle. So that's an increase in preload because we're going to still deliver blood into that left atrium to deliver to the left ventricle, so we're going to add to it. But what that means, if there's more blood in the left ventricle, is that it increases left atrial pressure because it's going to go backwards. And that's going to lead to an increase in pulmonary pressure. Which, in other words, is going to cause pulmonary edema. And if we keep going backwards, we end up in the right ventricle, and we're going to increase right ventricular afterload. The work required by the left ventricle to overcome the pressure in the pulmonary tissue. And that ultimately will force right ventricular cardiac hypertrophy. So we started with a left problem and we went all the way backwards to create a right-sided problem. We started with a problem right here, left ventricle. Forward was a problem with oxygen delivery. Backward, we created pressure differences that created an increase in resistance. And we can, because it's a closed system, it's going to end up all the way back and theoretically be a continuous problem. It's a positive feedback loop. It's a vicious cycle. It's a pathology based on something that started in a closed circuit and will have an effect both forward and backward on that closed circuit. Let's see if I've got a better way to show us. So here we have a prettier picture of our left ventricular failure. So forward effects, cardiac output, decreased tissue perfusion, that's where we were going to get our symptoms, confusion, maybe fatigue, that sort of thing that we talked about as a general. Kidney response, sympathetic response, that's going to give us an increase in heart rate. Backward effects are going to go from the left ventricle to the left atrium, to the lungs, to the right side of the heart. Decreased ejection, left ventricular preload is up, means an increase in pressure to the left atrium, has to work harder to overcome that resistance, and that goes backwards into the lungs. Right ventricular afterload goes up, pulmonary congestion is the afterload to the right heart, and then we get hypertrophy in response to that increased afterload. If our problem started on the right side, and when we go forward, we're going to have decreased output to the left ventricle. Right? Forward effects in our pathway means we're going to go, if we did our little drawing here with our lungs, and then we just closed it all in, oxygenated blood, systemic circulation, venous return, and to the lungs. So again, this time we're saying that the backward effects from the right heart, if we started here, so we have a weak ventricular right ventricle, then everything that goes backwards is going to start here and go backwards. And everything that's forward goes this way. So when we talk about forward effects, ultimately we're delivering a reduced amount of blood to the lungs, which means a reduced amount of blood to the left heart, which means decreased cardiac output. Decreased output to the left ventricle means decreased left ventricular cardiac output, and we have all the same presentation as we did with left-sided heart failure. So it doesn't matter what heart failure we're talking about, left-sided, right-sided, the forward effect is the same, poor cardiac output. The backward effects are what are going to change. So what we're saying in a right ventricular failure is there are no symptoms per se in the lungs. If it's a right ventricle failure, then the lungs are fine, the left ventricle is fine, but the right ventricle is faulty. So we start with a poor ejection fraction. which creates an increase in ventricular preload, increase in right atrial pressure, and that's going to force blood back into the systemic circulation. This will show up in a patient as a systemic congestion, swelling in the ankles, swelling in the jugulars. In the systemic circulation, there would be swelling. So the presentation is a little bit different. In left-sided heart failure, the backward effects affected the right heart and the lungs. So we had pulmonary congestion. This is the noisy difficulty breathing, right? When it's left-sided heart failure, the more common type of heart failure, we're going to hear noisy, difficult breathing. So the symptoms are pulmonary. In right-sided heart failure, the symptoms are systemic. If left-sided heart failure leads to right-sided heart failure, then we're going to have both. But until that happens, we can differentiate between left and right heart failure based on the backward effects, not the forward effects. I hope that makes sense. Now, there's one scenario where we could have, let's see if, there's a condition called cor pulmonale. Cor pulmonale. In cor pulmonale, there's a right-sided heart failure, but it's caused because of congestion in the lungs. So there's a scenario where there is an increase in pulmonary blood pressure. So maybe because of a lung issue, cystic fibrosis, some chronic obstructive diseases of the lungs that increase a pulmonary pressure. So we have an increase in pulmonary pressure. So this is an increase in pulmonary blood pressure. Remember, the right side doesn't have to overcome the same kind of pressure that the left side does in terms of trying to overcome pulmonary blood pressure versus systemic blood pressure. So if we have a scenario where we have an increase in blood pressure in the lung, then we're going to look at backward effects. And our backward effects are going to look like this. We're going to come backward to the right ventricle and the right atrium, and then into the systemic circulation, right? So that's our backwards effects. If we start with an increase in blood pressure, that represents increased afterload to the right ventricle. If we have increased afterload on the right ventricle is going to have to try to respond. So it's going to have a smaller ejection fraction. So it reduces the ejection fraction. It's a high pulmonary So here's our sequence of events. High pulmonary blood pressure starts the problem. That forces the right ventricle to try to overcome an increased afterload. It's not able to do it. A decrease in ejection fraction means an increase in right ventricle preload, and that leads us to an increase in right atrial pressure, and that backs us up into systemic edema. All of this is identical to right-sided heart failure, except that it started with a lung problem. So this is an exception to the rule. We say that the most common cause of right-sided heart failure is left-sided heart failure, but an additional cause can be an increase in pulmonary blood pressure because of a lung problem. So cor pulmonale results in right-sided heart failure, but it originated as a lung issue. Okay, let's get this in. So, treatment. Oh, come on. Treatment. We have to increase, our goal is to increase cardiac output. Like any treatment plan, we'd like to reverse the causes or fix the problem at its root. So we want to increase cardiac output. And one of the things we have to take into consideration, just like we did with myocardial infarction, is we have to start by trying to decrease cardiac workload. In other words, if our problem is we're not meeting demand, we have to try to reduce the demand. So we might do that with positive inotropic treatment. So some drugs that improve the strength of contraction without actually increasing the work required. So that's what digitalis does. It increases the available calcium to make it more available to the contractility properties of that cardiac muscle cell. We also want to decrease some of the compensations. So we want to decrease the sympathetic nervous system. So that might include the application of beta blockers. Remember those beta receptors. We want to minimize the effects of the renin-angiotensin activation as well. So that might include ACE inhibitors or the ARBs. Don't know how far you've gotten in pharmacy, but the ACE inhibitor is the blocking the conversion of angiotensin 1 to angiotensin 2, requires an enzyme called ACE, angiotensin converting enzyme. An inhibitor blocks that part of the pathway. The ARB category is going to also block the effectiveness of angiotensin 2, but it does it using a angiotensin receptor blocker. So it allows angiotensin 2 to be formed, but it blocks angiotensin 2's ability to match with its receptors. So in effect, angiotensin 2 in both situations is not allowed to exert its effects on blood vessels to cause vasoconstriction and so on. Okay, so we're trying to reduce workload on the heart, reduce the compensation mechanisms because they represent an increase in workload on the heart. So digitalis was our example. It improved contractility in the individual myocytes without increasing cardiac workload.